Periodontal disease deals with the various types of disease conditions affecting the supporting structures of the teeth, known as the periodontium. These diseases are extremely important to the dental profession, as the majority of teeth lost after the age of 30 are lost to periodontal disease. Before beginning a discussion of the diseases affecting the periodontium, it would seem wise to review the architecture of the normal periodontium. This is a drawing of a tooth located in a normal, healthy periodontium. The gingival crevice measures approximately 2 to 3 millimeters in depth, and there is no inflammation in the gingival tissues. Stop the cassette if necessary and study this drawing carefully, and familiarize yourself with each of the terms in the drawing. These terms will be utilized repeatedly during the lesson. The clinical criteria for a normal, healthy periodontium are quite simple, and most of these can be seen by looking at this clinical photograph of a young female with normal, healthy periodontium. The gingiva are pale pink, almost white in color, and have a number of small indentations on the surface. These small indentations are called stipples and are important in the recognition of early periodontal disease. Notice also that the gingival margins are sharp and closely adherent to the crowns of the teeth. Again, the gingival crevices in this individual would not be greater than 2 to 3 millimeters in depth. The bottom of the gingival crevice is determined by the epithelial attachment. The epithelial attachment adheres to the tooth and causes a tight seal around the neck of the tooth. The tooth is held within the alveolar bone by a series of fibers, which are known collectively as the periodontal ligament. Within the periodontal ligament are a number of small nests of odontogenic epithelium, called epithelial rests. The periodontal ligament is quite thin, with an average thickness of 0.25 to 0.40 millimeter. The periodontal ligament of an unerupted, non-functional tooth is even thinner, varying from 0.1 to 0.15 millimeters in thickness. Periodontal disease refers to any disease affecting the periodontium and can be divided into 4 major categories. Most periodontal diseases are inflammatory in origin, while dystrophies, neoplasias, and anomalies constitute the remainder of the lesions. In the 2 lessons on periodontal disease in this course, the primary emphasis will be on the inflammatory lesions. One of the most common diseases of mankind is gingivitis, or the inflammation of the gingiva. The textbook refers to a number of local and systemic factors which are frequently associated with gingivitis. This is a drawing of a portion of a tooth and the associated gingiva. Within the gingival crevice, there is a mass of calculus, which is irritating and ulcerating the adjacent gingival crevicular epithelium. This irritation and ulceration is causing an inflammatory reaction. This is gingivitis. This is a clinical photograph of a young person with gingivitis. The clinical characteristics of gingivitis can readily be seen by comparing this photograph with the one of the person with normal, healthy gingiva. Notice first the change in gingival coloration. In the normal, healthy gingiva, the color is pale pink, almost white, while in this case the gingival margin is dark red with a bluish or purple tint. Bleeding is a common sign. Most patients will complain of bleeding during toothbrushing or a pink toothbrush. This is another photograph of the patient with gingivitis. Look carefully at the mandibular anterior gingiva of this patient, and you will notice one of the earliest and most important signs of gingivitis. The gingivae in this area are swollen and edematous, and the light reflection shows that there is no stippling. Examination of this gingiva microscopically would reveal that it contains a mixed inflammatory infiltrate characterized by lymphocytes, monocytes, plasma cells, and polymorphonuclear leukocytes. Gingivitis is the earliest of the inflammatory types of periodontal disease, and by definition, there is no destruction of the periodontium. Local factors such as calculus are always associated with gingivitis, so professional scaling and polishing of the teeth is the preferred therapy. In addition, professional training of the patient in home care techniques will help prevent the occurrence of additional gingivitis. One special type of gingivitis is acute necrotizing ulcerative gingivitis. Acute necrotizing ulcerative gingivitis, or ANUG as it is sometimes called, is known to many people as trench mouth. Acute necrotizing ulcerative gingivitis was frequently seen in soldiers who occupied the trenches during World War I. It was thought to be an infectious disease at the time. However, it is now known to be an infection of saprophytic bacteria in people with low resistance. Saprophytic bacteria usually cause no damage in normal, healthy individuals. The soldiers, however, in the trenches in World War I were tired and had reduced resistance to disease. This is frequently the case in many college students today. The clinical features of acute necrotizing ulcerative gingivitis are disturbing and unpleasant. Look at this clinical photograph of a patient with acute necrotizing ulcerative gingivitis. Notice that the gingiva is beet red in color, indicating vascular hyperemia or congestion. These gingivae are very painful. Punched out erosions or ulcerations of the interdental papillae are present on the mandibular anterior gingiva. Gingival bleeding is frequently seen in these patients, and the ulcerated areas will be covered with a gray pseudomembrane. This is a close-up photograph of the gingiva in a patient with acute necrotizing ulcerative gingivitis. The areas of erosion or ulceration are plainly visible. These patients have a fetid, unpleasant mouth odor, combined with gingival tenderness and pain. Often these patients suffer from malaise and occasionally run a mild fever. The saprophytic bacteria which are present in acute necrotizing ulcerative gingivitis, or Vincent's disease, are an unnamed fusiform bacillus and a spirochete called Borrelia vincenti. These bacteria, combined with a decreased resistance to infection, are the etiologic factors of acute necrotizing ulcerative gingivitis. While this is a disturbing disease when first encountered, the gingival ulceration is limited in extent. Early therapy can be quite successful. Therapy for these lesions include professional scaling and polishing. Oxygenating agents, such as hydrogen peroxide, will flush out the necrotic debris and bacteria. Antibiotics may be prescribed. If the destruction is extensive, periodontal surgery may be needed to recontour the gingival margins.